want to be. So I have to be in the plane of that. So I'm moving this way in this picture. So X-ray, that is how I'm changing the angle here. Now while I'm in the inlet view, now I'm changing it in the angle of that definition of triangulation. Find out where you want to be in that plane that you get the picture. Just move it until you are where you need to be. Practically, it's much easier once we start doing that. You'll see that once the tip of it is fixed, that is all this calculation is, to make you start in a place that is favorable for you to end up where you need to be. Any questions regarding the anatomy? Anything? No?
You guys were ready to go lateral.
Okay, so let's go lateral then. Well, first we can start streaming anytime. Dr. Duke, we are in the Duke Institute in Florida. I'm going to give a 5-minute talk about the sacroiliac joint. Now, I'm going to be fast, but we will record it so you can watch it again. Now, about 25% or 1/4 of the patient who come to you with the back pain, the problem is not their back, it's sacroiliac joint. This is a statistic. And here you can look at that what the compilation of that is. And if they had a previous spinal fusion, if they have still back pain, 43% of that, again, statistic, is not back, is the sacroiliac joint. And you have to understand the sacroiliac joint as a actually adjacent segment to the L5S1. And we know that is often to have adjacent segment disease. Now, sacroiliac disease joint, we call it a joint, is not a joint. It should be a synostosis. Only time physiologically it moves is when a woman is giving birth. It open books mechanism, open up the pelvis for the baby to have more space to pass through. There are two parts to the disc. There's the ligamental part and the articular part of the disc. And you can see that here in this picture here, that it's stabilized with lots of ligaments, especially younger people when after giving birth, this ligament loosen, and this is your patient population. These are patients that they come to you with lots of problem, and obviously the other doctor have told them, your spine is fine, it's all in your head, go away, but once you look at them, please. Both part can cause the pain. As a matter of fact, there are different mechanisms to inject one part versus another to identify that. Now, the good news for us is most of the nerves is anterior or ventral to the joint, meaning the posterior is for us to treat safely. And here it is. Again, we are looking at the articular and ligamental part of that. Each of them can give patient pain. If you inject, you need to inject low volume in the articular part for diagnostic. I'll come back to that in a few minutes. This is the posterior aspect. What you need to know is that vessels are all and ventral. There are few vessels that are posterior, but it's a safe area to approach the disc through the posterior and lateral aspect. Now, my personal experience is that many of these people, they come and they're rejected by other surgeons, so the prevalence is very high. It's truly like field of dream. You build your practice around that, this patient will find you because they have been told no by many other surgeons. Now, the pattern of the pain is based on pain in the back, but these people can have radiculopathy. Radiculopathy does not rule out sacroiliac joint. As a matter of fact, it's a hallmark of it. The radiculopathy is based on the inflamed joint, inflaming especially L5 and S1, but as well as L4 nerve root, and it can give them a radiculopathic pattern. The films will not diagnose it for you. The films will tell you it's not a tumor, it's nothing else, but it's not going to make the diagnosis for you. So this is a typical patient. You know, yes, they have some problem there, but it doesn't fit. If you think it doesn't fit, always include the diagnostic there. And the diagnostic is easy. First, I'm going to bypass all that thing because, first of all, this is the radiculopathic pattern of the side joint, so it can't imitate anything for you. And here, this is the typical kind of pain that they describe to you. And I'm just going to bypass here and go to the provocation test, okay? So, 14 tests. They show you where the pain is. Ask them, look at them, you know. They look at you and put the finger back, turn them around, let them point to the pain. That's 14 tests. And then we have these different provocation tests, practically to provoke the joint to see if the pain is starting there. If 3 signs are positive, it's a high likelihood you are dealing with sacroiliac joint. And sacroiliac joint is a hard joint to provoke, but it's possible. We can talk about it later if you have a question. All of that, we will give you a booklet, something like a brochure about that. So you don't have to memorize any of that here. The hallmark of the diagnostic, based on all the insurances and all the societies, is 3 injection, low volume, 2 cc lidocaine or bupivacaine, and in the articular part of the joint, confirmed with contrast, as you see here, and confirmed with either C-arm or CT. But if 3 times, 75% of the pain goes away, even for hours. Same thing that the dentist put in your gum. If pain is gone while it's numb, this is the problem. And if this is the problem, the solution is fantastic. These are the patients who come and hug me. Literally, they stand up and hug me because they have been told it's all in your head. And now I did a half-an-hour surgery. Their life is changed. They are back to work. They regain their lives. Okay? So, again, that's how the injection looked like. And let's just go bypass all of that. I'm just bypassing the conservative treatment. Obviously, that's part of the solution. Let's talk about old-fashioned medial to lateral is dead. Let's not talk about that. Then you have the possibilities of the plug or a side bone. A screw is 7 times more strong than a nail for the same size. And most of my colleagues actually prefer screws to the plugs. There are different kind of screws. Screws with the internal hole works better based on my experience of having done about more than 200 patients. Screws better than plug. Bigger hole in the screw is better than no hole in the screw. Bigger the hole inside of the screw, faster they recover and faster you achieve stability. That's because bone grows into the hole and make it part of the fusion. Now I'm going to show you the views. Now, we talked about that, but for the big public, I go over that again. In the lateral view, you want to align the sciatic notch and the ala. And you see the sacrum here. And this is the body of the bone that you want to put your screws in. And again, here you see that, and you see the ala actually comes anterior or ventral to the body of the sacrum. But the sacrum is where you want to put your screws in. Then we have so-called inlet view, which is an axial view of the sacrum, where you have the slope of the S1, S2, and S3 aligned, so you get a hard kind of opaque bone here. And here it's the sacroiliac joint. And this is practically make sure that your screw end up in here in the middle of the sacrum and doesn't come anteriorly out or posteriorly, because here would be the L5 nerve root and here would be lots of structure you don't want to be. So your angle is right there. Now let's talk about the so-called true AP view of the sacrum, which we call the so-called outlet view, where actually our specimen shows a much better picture of that. We will see that hopefully. But here you see that S1, S2, and S3 neuroforamen sacroiliac joint. That is practically a true AP view of the. This is the outlet oblique view. There is a better, the true view actually is much better visible. Now, you have the nerve roots, but good news for you. All of them are ventral. None of them are posterior where you are approaching. So you are safe. Okay? So, and here is how it looked like. This is actually a patient I did already the surgery, and I'm doing surgery for the other side. I just took this picture for demonstration purpose. This is all the incision. This is all what it is to do the surgery. It's an incision that's less than 2 centimeters, and that you can do entire surgery. Now, you have two sacroiliac joints. In half of the time when I do surgery and most of the time you have problem on both sides. Like when you have 4 tires of your car, most of them wear at the same rate. But in half of the cases that I do unilateral approach, once they can walk on it, that takes the stress off the other side. You don't even have to do the other side. In half of them, you do need to go and do the other side. Another thing is that I don't do bilateral. This is one reason. The second reason I don't do bilateral at the same time is patient cannot step on that side for a few weeks. And if I do both sides, they cannot walk, especially elderly. If they don't walk, they can have blood clots, pulmonary embolism. That's all the problem you don't have to really deal with if you do unilateral. And guess what? Half of them, even they have bilateral symptoms, you don't have to do the other side. Now, let's talk. Walker, actually. Walker. Walker is better. Toe touch weight bearing with a walker. And we teach them even they can go stairs up and down with the walker. There's a way to teach them to really have a full life. Now, when I did a side bone, and truly 6 weeks is where they cannot step on it. With different screws and so on is different, but with the current screws that we are using, because the screw is big, has lots of internal hold, they fuse so fast, most of my patients telling me after 2 to 3 weeks they were okay to step on it. And they feel it if it's not time for it, okay? So this is the initial approach, and I'm going to show it on the cadaver, that we see the lateral view, and I literally put my guide wire here and here, and I draw the shadow of the S1, S2, S3. That's all I'm looking at on the skin. So on a true lateral view, where the sciatic notch and ala are aligned, I draw the shadow of the S1, S2, S3. That's all. If you try to get it all, you are not going to make it. But then, after you have that, we go to the inlet and all that. This is the final view. This is out of order, but let's look at that here. This is how that looked like. The shadow, I truly, literally draw that shadow of the S1, S2, S3 on the skin. Then I connect the upper part of the sacrum, the superior, posterior part of the sacrum, to the middle of the sciatic notch here. Literally, I connect this dot to the middle of that circle, if you imagine that's a circle. So that line would be like that. And that is your trajectory in the lateral view. And let's go back to the skin picture. And that is what this is. The superior posterior part of the sacrum to the middle of the sciatic notch. And now I draw it back here until on that line, I draw a line, until on that line, the tip of my marker is in the middle of that sciatic notch. Then at that point, that is already my entry point to the skin here, right there. Is entry point to the skin. The entry point to the bone, to the iliac crest, is obviously has to be above the ala, and preferably with the trident system, literally a little above the S1 and S2 disc. Now, if you do 2 screw technique, you have to choose your entry point, one below, one above that, or you can go all the way to S3. You can put your third screw in the S3. So if you would do 3 screws in a different way, you could put a screw here, screw here, screw here. If you do 2 screw technique, I usually use S2 and S3 because many of these patients, they may need that fusion in the S1. So I'm trying to save that for that. So let's just now go back to the views we talked about. Actually, let's go to the cadaver. I'm not going to talk about the results. You can get those papers.
Can you go back to the slide just for a moment?
Which one?
The one you showed me.
This one?
Yeah.
Yeah. So let's actually do it, okay? So, and I like to start doing with the drawing my marking on the patient actually. And this is actually a fantastic specimen for this purpose. Now, could you come and touch the patient with your machine? And we have aligned it already. You may have to bring the entire machine in. I think you're maximized on the slide already. You have to bring them all the machine in, please. Good. Now we have to adjust it a little. Get the X-ray. That's workable. Open this swing for a second. Just for a second, the swing. X-ray. That's perfect. Lock it. So, I'm hoping I don't need to explain that picture to you anymore. Marking pen. So, let's start with drawing the border of the S1, S2, and S3. You guys are able to see the S1, S2, and S3? X-ray. Again. Again. So, here, the ventral border of it. X-ray. The posterior border of it. And see, once you draw it on the skin, as well, you know exactly where the inlet and outlet view needs to be. That's another advantage of drawing it on the skin. Now, let's go from the superior part of the X-ray. X-ray. That almost there. X-ray. So, here, this line connect the superior part of here is practically the sacrum. Superior part of that to the X-ray here. Again, and that is your your trochanter or sciatic notch here, and this is our entry point right there, X-ray. So now my incision is about less than an inch parallel to the sacrum in that area, and parallel to the sacrum because then I can just move it better up and down. And in a regular patient, my incision is much smaller because live skin is more malleable, more plastic. In the cadaver, it becomes a little more rigid, so I'm going to make this incision much bigger than I usually would do it. Here. So, now, the next step, these are important facts. You remember that small little artery that was going around the sciatic notch? Thank you. So, for that reason, thank you. I use the dull end. Yeah, yes, exactly. I'm using the dull end. I'm going in, X-ray. You remember we said where we want to be? I'm hitting the iliac crest, X-ray. So, all I'm doing, I'm now on iliac crest. This is not my final position. May I have the dilator, please? This is to stabilize it. I go, look at that here. No, this is the small one. Give me the big one. Thank you. Now, I'm stabilizing it. Now, I am on the iliac crest. X-ray. I put it in the final position I want to be with the dull end. If there's an artery there, I'm pushing it away. X-ray. Again. About there. Now, Look at that, what I'm doing. Now I'm using the sharp edge. X-ray. Again. Do you see that I'm just barely X-ray aiming for above the S1, S2? That is a good position, and I'm about 2 millimeter anterior to the border of the bone. Now first I'm going to use a mallet. May I use the mallet?
But I thought your screw entry point was behind the anterior line of the sacrum.
It is. See, I'm on the bone. I am ventral to the border of the sacrum.
So the entry point you had on the monitor a few minutes ago was the entry into the body of the sacrum, not the iliac wing.
Well, this is the entry to the iliac bone.
Right.
By the time I have passed the iliac bone, I will be center of the sacrum, because it's about the centimeter.
Marks you had right there.
Mm-hmm.
These marks are your entry into the sacral body.
No,
not
no, no, no.
the
That, but look at the other picture on the other side without my marking there. Look at the on the.
Okay, this is the front of the sacrum.
Yeah,
I see. So
yeah.
this is entry into which bone though?
The iliac. That's the iliac. And look at the, if you look at the left picture there, you see as well. Compare the left and right.
Yes.
Yeah. I'm anterior or ventral to the sacrum in this projection.
So this is, where is this? On the front of this is not on the front of the sacrum.
No, this is just a marker. This is the marker there. This is, you see, I have those marking of the triangle of the sacrum there. That is, you're absolutely right. That is misleading. That is just my marking, my guide wire at that point. That is misleading. You're absolutely right. That's misleading. But those gray lines,
Front of the sacrum is here.
yes,
This line
that's
is
sacrum.
not here.
No, it's not there. That's right. Yeah, that we need to get a better picture on that. That is a little misleading. Yeah, you're absolutely right. So I am just notching it into iliac crest so the position doesn't move. That's all I'm doing. Now we go to the inlet view, please. Now, may I have that electric drill? Mm-hmm. Now, I see where the sacrum is, so I know where my axial view of the sacrum is. Now, probably we need to, no, that's good, lock that. And now open the slide. I already know I need to go back. Oh, are we max on the slide?
Towards you.
Toward your, sir, yeah. That's it, get X-ray now. So now turn it 90-degree clockwise, and I'm perfect. I'm perfect inlet view. You see that hard shadow of that, because I know where my sacrum is, so I didn't have to play around too much. Now, I'm just not going all the way in, just making sure I'm still good. Now let's go to inlet view, and again, I see,
Before you change,
I'm sorry.
what are you aiming? You're aiming for what?
I'm aiming for the middle of the sacrum.
Okay. So not the hard line in the front.
No, middle of the sacrum.
Above the hard line?
Above the hard line, before the L5S1.
Process lamina in the back.
Yeah.
Between the lamina and the hard bone in the front.
Let me just tell you exactly where I'm aiming. X-ray. X-ray. Nope, other way. X-ray. X-ray. That's about maybe even a little more anterior to that X-ray. That's about where I'm aiming.
All right, that's
X-ray?
scalpel plate.
Yeah, X-ray. About that area where I'm aiming. Okay. Now, please go to the outlet view. And sometimes I help it right there. X-ray. This is a beautiful picture. Now you see that there? I need to, in that plane, look at that picture. Now look at my hand motion. Now this is my hand motion. I'm moving in that direction. You see that there?
Are you going to cross the articular surface or the
I am.
Because it almost looked like you were aiming at the junction between the two.
No, well, you see that I have to reposition it to re-aim it because that wouldn't take me. So get the X-ray. You see that wouldn't take me where I need to go. X-ray now. This one more, and even more. X-ray. This one will take me where I need to go.
You want to
But-
aim between the two, S1 and
But
S2.
I want you to see, yeah, yeah. I want to go between the S1 and S2 foramen. That's what I'm aiming here in this view. But look at my hand motion. I think that's more important. X-ray. X-ray. You see that there? That's the hand motion. Yeah, yeah. You see that there? And now, but important as well, now you see why I made my incision in the skin that way. Because that's the motion that you mostly have to consider. X-ray now. So, now, X-ray, I go a little deeper. So, when I'm a centimeter there, my trajectory is okay there. Now let's go back to the inlet again. You feel it when you're going through the leaflet of the sacroiliac joint. That's mostly with the feeling. Go ahead. So here, I probably do need to reposition it a touch. Not much though. X-ray. I can even pull back a little and X-ray. X-ray. I feel I'm on the sacroiliac joint. I'm across. X-ray. Again, that's more than enough for me to be. Okay. Now, let me just open up this arc.
You're in the A law, but you're not in the body.
I'm on. No, actually, I passed the ALA. I'm in the body right now. I'll show you.
The tip.
I'll show you. Yeah, yeah. I'll show you. X-ray. Open this. Open that tilt for me. X-ray. Again. Again. Okay. Now let's go back to the outlet. So in here, you know, I could have gone a little more, you know, posterior, but you're not going that far because of this. The way this works, you are just about this less than an inch into the sacrum, and that's enough. X-ray. And again, you know, this is suboptimal, but I don't want to reposition all of that. This is still okay. I could have been, the better position would have been a little more. As a matter of fact, we are doing it. Let's do it.
Would have been more what? Inferior?
A little inferior, yeah, yeah. That would have been a little better. So you can reposition if you're not happy with that. X-ray. Again. 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 Sometimes it's harder to always find the same hole. X-ray. Yeah, it's going to find the same hole now, but that's fine.
But the most important thing to look for on this view is,
Mhm.
is the S1 and S2.
That's right. X-ray.
And make
No,
sure
in reality, in a regular case, I would accept that because you don't have to be, you know, perfect there.
with a single screw, you aim for that.
Yeah,
Not
yeah. X-ray.
S1 for aiming.
Yeah,
But with your system, does it go past that?
it will always pass that. In any system, it passes the sacroiliac joint. X-ray.
Not the joint, the notch, the foramen for the root.
No, no, I know. I stop short of it.
Okay, even with the final position of your system,
I always stop short of it.
you're short of it.
Short of the foramen. Yeah. And so let me
So
just.
it's acceptable to aim for it.
Yeah, it's acceptable to aim for it because you're not going that far. The only system that is reasonable to go and pass it if you truly go lateral to medial. This is perpendicular to the joint. You're always good stopping at the, you should stop short of the foramen, as a matter of fact, okay? Okay. X-ray. Let's use a 40. Okay, so I'm aiming for it and that's fine. Now, but another thing that we do different if you neuromonitor it. By neuromonitoring it, you know when you're too close, but getting a signal, and then you just don't go farther than that because the way this works is that when you get like very close to that, you get a signal at higher number, like 15 milliamp and so on. If you get a signal at 15 milliamp, it means you probably have another half a centimeter to go. Okay? If it's properly done, the neuromonitoring properly done.
Stimulating the EMG.
Yeah, yeah. You put a It's the stimulation on the entire construct, and then,
You look at the
yeah.
S1.
So, do you have it?
By the way, which foramen are you visualizing? The ventral foramen? Because
No, that is the point, that in that view, you are axial to the foramen. So you have the
it's
ventral.
ventral foramen, not the dorsal foramen,
Yeah,
because they're different.
yeah, they are different. They are different, but in the proper view, you're aligning them, more or less. That's why it looked like a truly. You see that there in the S2 is not aligned.
Yeah.
In the S1, it is aligned. But that is really doesn't matter because you can put it in your mind together how that works. Now, at this point, what is it, 40? I apologize. Give me a 45. I want to do a little longer, so just for demonstration purpose.
Zach, are you able to see the screw? You're going to use this view to place the screw?
I'm going to go back and forth, but I start this. So obviously I have dilated, and this is the whole system come assembled. It's not really a set like in a regular set is like 50 different instrumentation. This is all what it is. You go in, and obviously in a cadaver everything is dry, not less malleable, and in a real person we actually dilate. But then I'm on the bone already. X-ray. I'm on the bone. That's all what it is. Now mallet.
Concerned about the blood vessels there?
No, the blood vessels are right next to here. There's only one vessel,
Yes.
and I have already dilated. No, I have done 200 cases.
Want that self-drilling, self-tapping screw?
Hmm.
That grab the vessel?
You want to tell what we came up with that thing?
So we do have, you can either reverse, or we've also got dilators. We got sequential dilator and sleeve that
And,
unfortunately it's not ready today, but it will be ready
But
next week.
that will create a tubular channel to the bone where
Mhm.
the sides of that screw won't grab the artery? Is that
No,
what
the
you're
side of the screw as well is made as such that if it's something soft, it pushes it away. But if it's something hard, it grabs like a. It's made for that to exactly consider that possibility. In reality, the artery is pretty much far away from you, or if you choose that thing, because look at that entry point, and the artery comes at the bottom of that sciatic notch and goes. I'll go back to that picture. So here now, all I need to do is just tap it in and just turn, and tap it in and turn until it engages on the bone. I feel it's already trying to engage. X-ray. This guy has a really hard bone, but I'm getting in. I'm in. I'm engaged now. X-ray. All I need to do, no set in and out. All I need to do is just turn. That's all. X-ray. You see that there? It's advancing. Now, again, in this view, this is not the true sacroiliac joint, meaning that the joint that you see there, it's just part of the joint. But you feel when you are at the joint, and I'm almost feeling I'm getting close to the joint because it starts turning harder. X-ray. X-ray. And this is already drilling, tapping, compacting the material in the bone. That's all. X-ray. I'm at the joint now. I get harder. X-ray. Again. If you get there and it fights you, you just have to tap it a few more times. X-ray. Again. Now this guy has a really hard bone. X-ray. But I'm going through. Yep, catching. It gets really hard now, but that's a good thing. X-ray. You see that there? It advanced now. X-ray. X-ray. No, you can, or you can leave it there. It's not advancing. We are looking at it. So anytime you can take it. Now, I want to really truly pass in both leaflets. And you see now that's why you have this heavy thing, because it's really hard now. Okay, I'm using both hands now. X-ray. Now it's advancing a little. Now I'm through the second leaflet. Now I can take it out. I don't need that anymore. X-ray. So the trajectory is fixed now. X-ray. And now there is another view I didn't show you. I don't get it because I feel it, but I'm going to show it to you how you get it. It's called the iliac crest view. I don't get it because I feel it when I'm there, but let me show it to you. Open the arc, please. Open the arc where you see how far you are from, go down. About 35 degree, you get the iliac crest view. X-ray, where you see how far you are from iliac crest. You see that there? X-ray. Right. Or so-called teardrop, because you see that down there is iliac crest view. I don't get it. It's waste of time. Once you get feeling for it, you know where you are there. X-ray. How far you are from the iliac crest. X-ray.
It means through the joint.
No, head of the screw to the iliac crest here. You see it there? Let me show it to you.
Yes.
This is the iliac crest here, and I'm about 1.5 centimeter away from it. Oh, no, no, that is just to see how far I'm from the... Okay, X-ray. I'm getting close, I feel it. You see that there are, again, 2 leaflet of it. Open up the arc again for me. X-ray. Again. Again, here. X-ray. I'm right there, and I feel it. So I usually use my feeling rather for that. Okay, now let's go to neutral again. X-ray. You see that there? That is, I could even use a 50 screw. Okay, I can go a little more even and deform it. X-ray. So this is not about deciding the size of screw. Now I go to the inlet view. Open the tilt. Yeah, let's use the 45, or we can use 50s for this. Yeah, 50 on the side. X-ray. Now we are going to get a very good inlet view now. Now go a little north. Go north. Just a touch. Good. X-ray. Now this is the magic. Now, first of all, I see where my sacrum is. And I see where the side screws are. So first I'm going to go and align this X-ray. This is the let me have a screw to show it. Main screw here. So here, these are the inside of this main screw that you see there. You see that there? Now I have to bypass it. Now that's the time to start doing the fine adjustment. All you need to do, you need to use the side screws now. Now this is 1/4 of a change turn to do the final adjustment. You see that? Now it's 1/4. I'm going there, X-ray. Now I want to have a better inlet view. You see, I see multiple shadows there. Open the tilt, please. Let's see which direction. X-ray. Worse. X-ray. X-ray. Better. That's it. Okay. Now I first adjust those holes. X-ray. You see that the holes are adjusted. Now X-ray. Now these holes are adjusted. The sides, are you guys able to see that the holes almost are adjusted? Once actually get the X-ray, I'm going to show it to you. Yeah, that side where these are where the side screws are. They're aligned with those little holes there.
Oh, not this hole here.
No. We are looking right now at this hole
Those are the holes
and this hole
are
that
the
we are
big
looking.
trough.
First you see the big trough, then you know you have another quarter turn to go. And that is the last. You really don't want to go back. That you have to adjust it so that you just finish it up and you're done. So once you have it in the final quarter, then it's about time to adjust. Now, get the X-ray. Now I'm going slowly, very slowly now. Not because this is hard. It's hard to go slow X-ray. And now I'm actually bypassed it. I'm already where I need to be. But now in this case, I'm going to go a little back so you see what it looked like. X-ray. So you see that they're adjusted. So may I have a marking pen so I can show it to you on a piece of, on here. The pen. Okay, so here it is. You go and adjust these holes on the side. First you see the big hole in the middle. You know, you have a quarter of a turn. Then you adjust the hole on the side. Then you go and make those two holes what we call anti-parallel, meaning they look like that. And the reason for that is the sacroiliac sacrum is a wedge. Once you go from this to this, you have the optimum position for the side screws. So we saw the big hole, we see the small hole, and now I'm going to go X-ray. Almost there. X-ray. You see that there now? They're anti-parallel. You're done. Okay? So now I take it out here. The sleeve stays in. All of this comes out. Now it may have the side screws. Now, that is, I think, the magic of it. You don't have to repeat all of that for the second and the third screw like any other system. Here, you go to the side here. It let you go only one direction and one direction only. X-ray. Now, could you go back to the, now I go back again to the outlet view and I'm turning. That's all I'm doing. It grabbed already on that. That's all. X-ray now, and you see what happens now. X-ray. Go a little south, please. And maybe drop it even a little more. X-ray on the tilt. Yeah, on the tilt as well. Open the tilt. X-ray. Okay, here. Do you see the tip of this coming out already? Are you able to see that? X-ray. Go more. Again. 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 And that's all what it is. Yeah. Again. I'm passing again the sacroiliac joint. X-ray. Again. Now I'm entering the ala, because ala is mostly up there. Ala is not farther down. That's why I wasn't passing ala before. Now I am. X-ray. You see that there? All I'm doing is just turning it. X-ray. Again. And then it become hard. X-ray. X-ray. When it's locking into the, here, it's getting hard now. So quarter turn or, okay. They may have the other T for that. I can take that one, yeah. No, it's impacted.
Here, take this.
No, it came out, that's fine. So, a quarter turn, then it become easier again, X-ray. So, I think that's it, correct? It's sitting, it's connecting, the main screw and side screw are now connecting. See, this is inside, this is how it looked like. The sleeve, let it go only in one direction. I went from top to bottom, so it's coming at this angle, it's going through this hole here, and then it's coming, and then it's going to lock into that top of that screw. And the trajectory is going to just fix it there. Okay, here it is. It's getting easier. Now, this is the idea to not ever lose this. This is the idea of this. First, I'm pulling it back. They are still not disconnecting. But now I'm pulling it back, and now they disconnect. So that you never lose that in a patient. Because re-engaging, it's very, very difficult. But you won't lose that, and here, disconnect, works beautifully. And then, done. X-ray. And now I repeat the same thing with the other screw. May I have the other one, please?
You have it up here somewhere.
Okay. Here, is that the one? Yeah, I just disconnected it. I took it off to show it, yeah. So, and engaging it, obviously somebody in the back table put it for you together. You turn, turn, turn until it's in, and then You let it sit in. And now I do the same thing with the other side. That's all. X-ray. Here, you see the tip of it, and it's already, if you need to tap it, you just make a notch in the hole, notch in the bone. X-ray. Here we go. It's engaging. X-ray. Now, it looked like we did it for a long time now. We are talking and doing it and so on. Every time we do it, just do it. How long does it take us? 9 to 12 minutes. The entire process is, literally 9 to 12 minutes. X-ray. And you see that there? It's just going in. X-ray.
So, what if you don't feel comfortable deploying the side screws?
Then you can do one or second screw, or you can put the second big screw.
Well, what about just the big screw?
The problem with the just big screw is that then actually they still can somewhat rotate.
Of course.
Yeah, but nothing says that you have to do one or another. You can do either way.
Have you done studies, any biomechanical studies with just the one screw?
We've done the biomechanical testing on the one screw to show
Mhm.
the strength of the one screw, but not biomechanical.
Mhm.
The strength of the one screw is sufficient
Okay.
for cantilever heading tests.
So let me see here. I think it may have disconnected. I just here. Okay, now I have to be actually paying a little attention, because in certain angle you can disconnect. You have to just keep pressure and keep turning. X-ray. And getting in. Yeah. X-ray. We got CAT scan and so on. We get CAT scan on all this thing and so on. I sent you a picture of the CAT scan, how it looked like on this specimen, after we ship it back to Minnesota. X-ray. I'm in.
That's it. I can see
Yeah.
it on the X-ray.
I'm
I
a-
can see the little
yeah,
curve
I feel it.
cavity.
I feel it.
This is for pulling back.
Yeah, I'm good. X-ray. I think I'm good. I'm in. Good. Okay, so then I just engage it back. X-ray. Again. Okay. X-ray. Yeah, I think I just have to push it back now, right?
Who's the rep for this territory?
At the moment, I have reps that are in Fort Lauderdale. We get them to come here, or we should find somebody local.
And for the first case or two, would somebody be
No, I'll come here and I'm happy to do it with you. I think this is one of the things that the learning curve is much faster if if you do it together. I have my the privileges for Florida, so I'm happy to come in and
you
yeah.
have a medical license in Florida?
yeah. I have my privileges. I just have to get the privileges for here. So may I? So the rest of it is after you disconnect that is, do you have the thing for that? You put that in. That's it. X-ray. Now let's go to get an inlet view of that. Get X-ray. Now, it is actually not a bad idea. Try to catch a little of the hard bone of the other side. There's nothing wrong with that.
What do you mean the other side?
Well,
Anteriorly?
yeah, like that if the end of your screw, you will see if I will send you some picture of my cases where the tip of the screw is right at the periostal part of the margin of the other side. It's not a bad idea. Actually make it stronger, 30% more strong.
How do you size
The side screw here, I just was usually they come in a set. Yeah, that's a certain side. We have done some of measurements. So here I'm using,
What if you want to use a shorter side screw?
and that is why you can combine it as you wish. Based on your experiment and the x-rays and so on, you can combine it as you wish. Here, you remember I used the 45 main screw and 50 side screws.
So
Okay?
if you want to do a 45 main and a 40 side, it'd be okay.
That's absolutely all right. No, but you just,
Screw include every main screw in the kit.
but you know, what you notice is that, you know, actually the real reason I use the different kind of screw is we are still ongoing making those measurements. I'm going to get a CAT scan and I do those measurements how it looks like. Usually we recommend use a 45 with a 45. Generally everything will be fine. But here I'm still trying to do some of the calculation about how the things are. So that's why I use the
Developing the technique.
yeah, it's ongoing things. Generally, though, I can tell you though that you want to use for the upper screw actually for screw here a little shorter screw than here. Okay, and I want to use the longest screw I can use without being too long, and that's sort of almost like a fine art what to be. Now, in reality, in this patient, I think that is perfect. That's exactly where it need to be. And I will send you the CT. We'll get a CT, and I will send a CT of this patient. So how the inside everything look like. I do most of those calculations before. There are certain way on the CT you can make those calculations. What's the optimum kind of length of that? And but we can go over that in person. So this is the sacroiliac joint now. Now, what is and we will practice it on maybe on a foam model and so on, or if you want, you can practice the other side of this.
No, I'll let the other doctor do the
Yeah, and then, but I really, before you go, I really want to show you as well the OLIF procedure, because if you have, what time do you have to go? Yeah.
I'll watch your video.
Oh, okay. It takes doing the OLIF. If I don't explain it, we do it usually in 7 minutes. What time is it now? 11:60. So you have to be gone at 12, or so. What about we just if you can get a second C-arm, we can within the next 20 minutes we will do a OLIF that you see what the steps are. Would that be all right? Okay, let's bring a second C-arm. Why don't I adjust it? I adjust this. You go and get the second C-arm, okay? Because the second C-arm will come here, go for the AP. I will use that for my lateral, and I will adjust. Just I take care of it. You just go and get the other C-arm.
Be back shortly.
Okay.
Thank you.
Mm-hmm.
Also, we need to get gown. Anyone that's got I don't want this
Mm-hmm. Yeah. Well, I put the gown outside. Mm-hmm.
I'll be back.
Mm-hmm.
That was very good though.
Oh, thanks.
You want to continue to stream right now?
Yes, we can just continue. I'm just going to set up the.
Broadcast real quick.
Mm-hmm.
Anybody else need coffee besides me?
Okay. Usually about an inch.
Really? So,
Hmm.
I mean, close to 2 centimeters.
Yeah, more than usually about 2 centimeter is a realistic thing. Yeah. So. So this is Amanda. This is the one that we want to have a nice thing, nice view. Yeah, I want to record that. You know, like if you want to put it like here, that would be probably a good angle, just from here to there, to or maybe even from here. We don't need any of that here, so we can take this away.
Do you want the screen in there?
No, screen doesn't have to be there. If you just can show me, that's good enough. And if you have two, you can one record the screen, one record the thing. Yeah, that would be great. Yeah. But okay. Mm-hmm.
This is not the right one. Louise, you want? This is not the right, alright.
Especially when you're talking about getting windows parallel.
Yeah.
I think having this nice image would help.
Yep. Yep. Now, yeah. If you can forward this to me, I can integrate in my presentation.
Can you share your PowerPoint presentation with me? Because that's a lot of stuff that I need to
Yeah.
maybe add to this.
With this on the inspired spine presentation, side joint master. And if you put that there. Okay.
Spine, spine.
Presentations. The side joint fusion master.
So I'll have the screen on this one and on
no, this is the way it's supposed to be, but I need to adjust it. If you just get an X-ray for me on this one. Okay, now we go up. Good, get the X-ray. Good, getting there. Now let the table can come down. Can we bring the table down a little? You got it, thanks. Good, that's it. Now come south a little more. Good, get the X-ray. Good, it comes down with the table. No, actually your machine need to go up or table need to come down. Good, more, stop, X-ray. That's it, we're getting there. Now, table even a little more down. Stop, X-ray. These are good X-ray machines. Good. Now, do you see, get the X-ray? Do you see that line, that metal piece? Make it vertical. Yeah, it need to be exactly vertical. No? Other way? Turn it upside, don't turn it upside down. Make it back where it was. And now turn it little by little. Yeah, more. Stop. Now right, left, right. No, not upside down. Right, left, right. Yeah, that's it. Now go up with your machine more. Stop there. Now open the swing and the arc for me. Good. X-ray. Again. Okay, X-ray. Now go up 1 more inch and go north 1 more inch. North 1 more inch. X-ray. Okay, I think that will work. What do you think? Ken? I think that will work. Spinal needle? Yeah, it'll be on this side. And do you have a spinal? Okay. X-ray. Yeah, we can bring now AP machine as well in. So let me actually bring the AP machine in so we can just, and we'll just cruise, okay? And I want to record the, yeah, I'm bringing it in, don't worry. So we need to go up with this machine. Let's go up. Okay, that's about where it needs to be. You'll adjust it in a second. So, open the back two on that machine. The swing and the slide of this machine. I called swing and slide the back two.
There's the slide.
Okay, swing.
Swing,
Swing.
we'll move the machine itself.
Oh, it doesn't swing?
No, this one is not working.
Oh, okay. Good. Get the X-ray now. Ooh, how do I get the look at the pictures? Ooh, that's in my way. Okay, just no. Turn it 90-degree clockwise.
This way, you want it
Yep. Up and down. That's right. That's it. Okay, lock it right there.
Good?
Get the X-ray. Oh, moved. It moved. Get the X-ray. Get the X-ray. Okay, get the X-ray. Okay, lock it there. Lock it right there. Is everything locked?
Everything's locked.
So the problem is, the monitor is not where I can look at it right now. Can you move the monitor maybe here?
In fact, we're doing surgery, we want to bring both monitors over here
Yeah, that is usually, but for demonstration purpose, that's fine.
Can you see it?
Yeah, if you bring it more here, yeah, more, that's it. And that's actually good as well for Dr. Duke and so on because they can look at everything directly here. And and I need to be able to look at both AP and that's good. That's fine. That's fine.
Is there a way that we can get this on the broadcast, or is only one going to go on the broadcast?
One.
So can you now open again? Can you open now this for me, the swing and the arc? X-ray. Okay, lock it right there. That's perfect. We are going to do that one. That's the 5, 4, 3, 4. 5, 4, 3, 4. Yeah, we can do that one. So we are ready for Dr. Duke, and it's just going to take. Let's just cruise and do it in shortest possible time. Now that is as well the problem because this is in my way. Huh. Yeah, if you can.
You want this one brought over?
Yeah, let's bring this over because it is in my way. Usually we put it south and we have a setup of the room, but here we just have to work around this. Now if that,
Go too far with this. Here,
okay. You want me to help you? Okay. Okay. Or is there a way to put that picture on that monitor? Because if you could put that. Hmm. Yeah, we have pictures that shows the setup in the room and so on. This is not our setup, so that's why it sounds complicated. But the setup, we have literally a map of the war, how things supposed to be. Do you need help? Tell me if I want me pull it more toward myself.
you can pull it a little more.
Okay, yeah, you need to do like this. That should be all right now. You should be all right now. Yep, that's perfect. That's perfect. Or maybe, yeah, no, that's fine. Maybe just a touch more. That's it. Okay, I'm ready. You want to call Dr. Duke? Do you have a good view? Okay, as well from us? From us? Yeah. Okay. So usually I ask for AP or lateral, but if I say X-ray or if I say AP lateral, then I mean both. And when we get both, I'm sure you're familiar, you have to delay them half a second, otherwise they interfere with each other.
And you, well, actually, this one delays anyway, so it takes me about 2 seconds.
Sounds good.
I've got some great news. Lunch is here.
Oh, good.
As soon as we're done with this, we can go get lunch.
So look good. So I'm just going to do the procedure, and then at your discretion, if you have any question, we can do as much as you want. Let's do the. Good. Then let's just do the procedure. Okay, is everybody ready? Ken?
Yes, sir.
Ready? Okay, I have my pictures. I'm going to do a L3 for OLIF. Let's start, time start. AP? lateral, I'm sorry, AP. Again. Lateral. 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 Local, given, knife. Please stimulate at 3 milliamp.
3.
AP lateral. AP lateral.
Is that connected to your monitoring system?
Yes. AP lateral. I'm getting to the Cambian triangle, neurophysiology. Please pay attention. X-ray in the foramen. Am I good at 3?
Third 3.
Recheck at 4.
4's clear.
Taking it. Stop. I'm dilating. X-ray. Neuromonitoring. Pay attention. Anesthesia. You may get a vagal response. X-ray. X-ray. Again. Mallet. X-ray. Here we go. Hold. X-ray. Mallet back. X-ray. But both X-rays, please. Okay. All the way to the other side. Tube and the barrel. X-ray. Mallet. Both X-rays. X-ray. Oh, both X-rays, please.
Yes.
Go. Lateral as well. Both X-rays, please.
This one is just on,
I see.
that one is on top.
Tube, X-ray,
No, I don't think the second one here.
X-ray,
It's not, I don't think I'm right into that.
drill, X-ray. So it's going to be a 3314.
314.
X-ray. Again. So you're not shooting the laterals for me. Please, always shoot the lateral. X-ray. And Doug has been in the surgery. This is truly the flow of the surgery. No different. X-ray. X-ray. Now, a real bad disc, this is a normal disc, so it is much harder to do this on a normal disc because tissue is more viable. In a bad disc, tissue falls apart. And our average disc time, spending time inside of the disc, is about 5 minutes. So here, chunk of material. And you feel when you're on the hard bone. You feel the high frequency vibration when you're on the hard bone. No, I'm going to put it here for demonstration purpose. Give me now the rake. X-ray. That is the action. X-ray. Again. I feel it how it's on the bone. So I feel the end plates. Is the tricalcium phosphate ready?
Yes.
Mm-hmm. I feel that I'm hitting hard bone. Tricalcium phosphate. X-ray. Cage ready.
Cage ready.
X-ray. Cage.
3314.
Doc, you remember I said fascia? This is a huge cage. Here, this is what I meant by that. X-ray, I passed it easily. X-ray, neuromonitoring, anesthesia, cage is going in, small mallet. X-ray, X-ray, mallet, small first, notch it in, and big mallet. Here we go. Hold, X-ray, mallet, X-ray, coker, or the wrench, I got it. Small mallet. This time, X-ray, done. So generally, we spend about, from the beginning of the surgery until the first cage is in, it takes us usually about 7 to 8 minutes. But the second cage, Doug, you remember the one that we were there? You were there?
2 levels, 4 to 6 minutes.
46 minutes. So in the first 10, 12 minutes, 2 cages are in, and then the rest
I
we
did
spend.
this 15 years ago.
Yeah.
for the first time.
So you have
Why
lots.
do you not call it a transforaminal? Why
Hmm?
do you call it OLIF?
Well, it is the extraforaminal kind of approach. The name doesn't really matter. The name
But it's
doesn't.
confusing, that's all.
Yeah, the name doesn't matter. But so we did record everything. Good. And at this point, then the rest is the posterolateral fusion.
Hardware,
Yeah,
screws.
percutaneous, and we did that. The case 6 screws, 2 rods, 2 cages, all in under an hour, and that's our average time for 2 level. Our average time is about 55 minutes.
How you know the
And
size
but
of the cage?
you feel it when you put the tube in.
How many template?
You
If
do.
it's very collapsed,
You do, but it's all waste of time. You once the tube is in, you see this tube.
Measuring height
I see.
into the access point.
This is how I measure it. When I put it in, based on how easy or hard I can move it, and based on how easy or hard I can turn this, I get a good idea what size.
I see.
And the length of the thing, I measure it by the drill, by the drill. Yeah. And now, more important that this is a short surgery and it's short anesthesia time is that these people, literally, I took picture out there on my LinkedIn. So, Amanda, can you get my LinkedIn from? Those people are smiling at you 2 hours after the surgery and leaving the surgery center. I have never had a surgery that I could do that. That the patient walks to their car and walk out of the surgery center and drive home. They're in pain. They're going to be in pain. But at least this is now. We have done 3-level surgery in our surgery centers. Not a single person has stayed over the night in my surgery center in the last 6 years. Not a single person. And obviously, I'm using younger people and less dramatic, less psychosocial issues, less pain as a person. But you know those patients. Okay, if a patient comes and everything is super dramatic and painful, that's not a surgery center case. You want to have the right people in the right place. So this is.
What is it?
Thank
What are
you.
thinking?
This is a.
I've seen this many
This is
times.
a patient
You
of
know
mine.
that I'm the pioneer of outpatient fusion surgery
Yeah.
in the United States and the world.
And you should
I've been doing
take
rehabilitation
ownership of that.
that's Open,
Yeah.
with osteotomy, corrected
Mhm.
deformity, segmental instrumentation, and body cages each level. 2 hours going home.
And
That's 8 years now.
you should capitalize that and on this because
I am doing
this is how they look like. Contrary, this is not the face of spinal fusion patient.
I get it, it's great,
Yeah.
but you obviously don't know what I've been doing.
I know I don't. Obviously, I don't.
If you did, we would be
I wouldn't be
this is great.
preaching.
We're both doing the same thing.
Yeah, good. That we should do more. We should teach other people do that. We should because I think
I've
the
been
difference
publishing
is
it,
good.
I've been publishing it for years,
Excellent.
and I'm glad.
Well,
you're
thank you for
paired
your
up-
work.
You're paired up with a company that's promoting it, which is good.
Yeah.
Yeah, the company that I use doesn't promote it.
And that is what we need to change. We need to pair up with people who do promote it because that is what's going to change the people. Like, now in a young person doesn't really change much if you do a 1 hour or
We've done 85,
Yeah.
90-year-old,
Yeah.
4-level, L2 to S1
here you are,
construction.
and that makes a
4-hour
difference.
surgery,
Yeah,
200 cc's of blood loss, go home 2 hours.
And you
later,
can-
single patient.
yep. Here you go.
We call them the dancing fusion because
Dancing
they can dance before they leave. And they all dance.
Good.
But we stopped doing it years ago because
Why is that? Why
we
did you?
stopped doing the videos.
Oh, videos. Okay. No, I still do the
I've been
videos.
doing it for 8 years. I know you're still at that beginning stage.
Yes, I am.
I'm past that now
Good.
in my career. We still promote the videos, but not doing the dancing.
No, we need to bring it out to the entire United States. That's what we need to do. It's not enough to do it in one place. We need to teach younger people to do that, and we need to bring it. We need to. Now, I was doing surgery in a university.
I've tried.
Well, I'm still going to try.
Yeah, you know, keep trying. I'm
Yeah,
not telling
yeah.
you not to.
No, I was in a university. I started my surgery at 11. No, actually, the cut was at 11:20. My cut was at 11:20, and I did this one surgery. Then I waited 1.5 hours, and I did a second surgery. And I was still faster than that academic professor who started at 8 o'clock and did only 1-level fusion.
Listen, I agree with you.
Yeah.
We both see the potential for this outpatient,
Yeah.
multi-level fusion, but the problem with your technique,
Mm-hmm.
the reality
Mm-hmm.
is that most people who need a fusion need deformity corrected,
Mm-hmm.
and you can't do that.
I show you my data. We published a paper.
It's impossible. Trust me, I've done over 1,000 T-lifts in
Mhm.
my career, 26
Yeah.
years, 1,000
Mm-hmm.
T-lifts.
Mm-hmm.
And the problem is the facet joints are too sclerotic,
Mm-hmm.
they have too much osteophyte.
Mm-hmm.
You cannot distract them, you cannot put them back in lordosis, it's
Mhm.
impossible. You have to remove the joints, you have to do an
Mhm.
osteotomy.
Let me show you my data.
If you try to put that giant cage in and correct deformity without removing the facet joints and the kind of patients that I do,
Mm-hmm.
you're gonna get a nail plate fracture.
Yep.